I think we're going to go ahead and get started so we can give Jason his full time. So I want to welcome everybody to our COVID-19 weekly seminar series. Just a friendly reminder again for anybody who's joined just recently to mute your audio, turn off your video, just so we can have the presentation run more smoothly. And also I wanted to remind everybody that next week we're moving this COVID seminar series to the Friday noon time slot because we don't want to overlap with the CTSI Distinguished Speaker Seminar series that is going to be starting on Wednesday, October 7th. So please remember this seminar is now going to be held on Fridays at noon. So I'm really delighted to introduce Jason Hinman as our UCLA COVID-19 seminar series speaker today. Jason is assistant professor in residence in the Department of Neurology at UCLA, and he's a West LA VA staff neurologist as well. Jason works in the area of translational neuroscience that's focused on cerebral microvascular disease and on white matter damage and repair. And as you'll see when I tell you a bit more about Jason, he's really highly educated in this area with a Bachelor of Arts with honors in psychology from Case Western Reserve, magna cum laude, followed by an MD PhD degree, again magna cum laude, this time from Boston University. He then did his medicine residency at Cedars-Sinai, followed by an adult neurology fellowship at UCLA. This was followed by a fellowship in translational stroke research and a vascular neurology fellowship. And then to top it all, he also did neurorehabilitation training. And he's board certified in adult neurology and vascular neurology. So you can see he's really highly qualified to speak to us today. He has a very impressive CV and he's an NIH funded investigator and has won numerous awards for his work in stroke and aging. He's also very active in many clinical trials and drug discovery efforts, which makes his work very translational. Now, since the COVID-19 pandemic hit, he's been using his considerable expertise in cerebrovascular biology to help understand the cerebrovascular complications of COVID-19, which we all know and begun to appreciate are very important complications of this terrible disease. And so the title of his talk today is Fear and Loathing in 2020. SARS-CoV-2 related cerebrovascular complications and their mechanisms. So welcome, Jason. We're really excited to hear your talk, and please go ahead and take over.
Sure. Thank you, Brigitte. Thank you for that very kind and detailed introduction. Certainly that amount of training went by awfully quickly. So it's funny to reflect back on how long it actually took. I'm delighted to share with you the work we've done today, and I thought that, so I was thinking about the title, you certainly hope to have project some more optimism, but I think one feature of this particularly challenging disease is that it's come with a wide variety of complications that, you know, we think of it as a respiratory pandemic, but it's certainly defying that textbook definition. And I think I'll try to show you today what we know and understand about the risk of cerebrovascular complications associated with SARS-CoV-2, and then some of the work from our laboratory that's begun to address what may be an underlying mechanism driving that association. And we're certainly in the early stages of this work, but I think we've made some relevant and important insights, and I'll share those with you. Let's see if we can advance. Oh, there we go. So just some perspective, you know, as we're dealing with this, it's an ongoing issue, which I think for most of us doing this work is, you know, obviously we're always studying disease that's ongoing, but not quite in the sort of real-time sense that we've been dealing with COVID-19. This is a map of active cases from September 26th, a few days ago. There were about 7 million worldwide. Approximately 1% are estimated to be serious infections. If you use the current estimate of the stroke risk, which we'll review that data, it's about 1.8%. So if you apply that number across the current active cases worldwide, there's as many as 138,000 strokes happening now in the next previous 3.5 days and the coming 3.5 days. And if you focus just on the serious cases in which that stroke risk is primarily based upon, there are about 1,100 strokes happening right now as a result of COVID-19. And that's about half of the US daily stroke burden annually. So this is a significant contributor to cerebrovascular mortality, morbidity and mortality. As I mentioned, it's been interesting to study this disorder because there are a number of dynamic interactions that are occurring in real time. So, we think that there's an association of SARS-CoV-2 and the COVID-19 clinical syndrome with acute stroke, whether there are a myriad of mechanisms that could be driving that direct cause, but it appears that the data suggest about a 2 to 5 times increased risk of acute stroke in association with SARS-CoV-2 infection. There's also a dynamic in which the broad community and societal impacts of COVID-19 have led to delays in normal stroke care, with early on in the spring a nearly 40% decline in stroke admissions worldwide. That doesn't have a direct cause, but an indirect impact on cerebrovascular disease. And then there's a reciprocal relationship in which cerebrovascular disease and a history of cerebrovascular damage, stroke, and other injuries appears to also increase the risk of getting and developing severe COVID-19 reactions. And that is relatively underexplored. It's not been well done from the data in this country yet. So a lot of the demographic data that's driving that association comes from China and Europe, and I think it remains to be seen what possible mechanisms may be driving that. What we're going to do today during the talk is review the clinical data supporting the association of stroke with the COVID-19 clinical syndrome, talk about some of the proposed mechanisms that could be driving that, and then show you some experimental data that we've focused on, which is really what may be some mechanisms of viral susceptibility in the brain endothelium that could be causing and increasing the risk for acute stroke. And the reason that we focused on that element of it is because it has some overlap with the overarching themes of my laboratory and the basic underpinnings of what molecular mechanisms are driving cerebrovascular disease in a broad sense. First, let me say that this audience may need some background information. I put up just the various definitions of stroke, many of which are being included in the literature. And there's a tendency to want to lump these in part due to the rapid generation of data about SARS-CoV-2 and COVID-19. I'm showing examples here of COVID-19 related strokes, including what we call microvascular strokes that occur in the tiny blood vessels of the brain, typically in the deeper regions or on the surface of the cerebral cortex, as an example here on the left. We've also seen so-called large vessel strokes associated with COVID-19, where the proximal middle cerebral or internal carotid arteries are blocked, resulting in a large area of cerebral damage. There's a variety of hemorrhagic complications. Here I'm showing a small intracerebral hemorrhage. And we've also had subarachnoid hemorrhage and other forms of bleeding in the brain described in association with COVID-19. And then also cerebral venous thrombosis here in the jugular vein can cause both cerebral hemorrhage and be associated with COVID-19. And these are all forms of stroke that in the broad literature around this disease have generally been lumped together. The two most common presentations of stroke that appear to be associated with COVID-19 are these large vessel strokes and then microvascular strokes, with hemorrhagic events and venous thrombosis being more rare in the broad sense, but also more rare in association with COVID-19. I mentioned the delay in care, and I think this is just relevant. This on the left here is data from the Veterans Hospital system showing that in the early weeks of the pandemic, there was a precipitous decline in stroke admissions week over week, approximately 50% decline during the early months of the pandemic. The blue lines represent 2019, and the orange line here represents 2020, and you can see a precipitous drop that occurred. That's somewhat stabilized. This is national data presented in the New England Journal using an automated system that we employ to read out CT and MRI scans for patients evaluated for acute stroke. This is their national, from a corporation that does that analytic evaluation called RAPID. This is the temporal association of their automated system that reads out scans in real time, showing a precipitous drop during the early statewide closure orders that was nearly 40% decline. And again, that's come up somewhat, but we're still having issues, frankly, worldwide with patients coming in to be evaluated. And so, again, this is an indirect impact of COVID-19 on stroke, but nonetheless, potentially of far greater impact than the data I'll show you. Now, as we've learned more about this respiratory pandemic, we now understand that it has, quite frankly, a wide variety of systemic complications that its predecessors in the coronavirus family did not particularly demonstrate. Now, one possibility is that those predecessors like MERS and SARS-CoV-1 were not as widely distributed across the world, and therefore what we're seeing is simply the various manifestations of severe disease in a widely distributed virus. However, it is clear that there are significant and numerous neurologic complications, some of which can be the harbinger of the disease, such as ageusia, the lack of taste, anosmia, the lack of smell, but also as more severe ones, including encephalopathy, Guillain-Barré, and the focus of the rest of our talk today, stroke. But I say this just to put in context that I think this virus is likely to have, widespread direct influences on these various organs. And so I approach this discussion with a hypothesis that there is direct invasion of the virus into the brain, most likely mediated through the endothelium, and that is the focus of the mechanistic work I'll tell you later. Now, if we want to understand more about how we came to know that there is an association of SARS-CoV-2 with stroke, we simply have to look at the map. This is a map of flight patterns that essentially describes the evolution of the virus across the world. And we can simply utilize this map with a slight delay to understand how we came to know that there's an association of SARS-CoV-2 with stroke. And we'll start in China, we'll migrate to Italy, we'll move from there to London, and then finally we'll find our way to New York, and then ultimately to Los Angeles. And I see now my arrows are geographically misplaced, but we'll move on from that. The data is not misplaced. Let's start in Wuhan and review data that looked at, and I'm sorry I don't have this fully referenced in the PowerPoint, but if folks are interested, they can email me and I can direct them to the relevant references. But here, this study looked at the rate of new neurologic events in COVID-19 during the early phase, at least in China, of the pandemic. And what they found was a 3.5-fold increased risk of new neurologic events, and 9.4 in patients who were having severe or critical COVID-19. And this was then suggested to be associated with a significant odds ratio. Some of the risk factors that were associated with this increased risk appeared to be elderly age in the 6th, 7th, and 8th decades, and then also pre-existing neurologic comorbidities, and these were lumped to include any number of things, including prior stroke and seizure and other things. Sorry, let's go back 1 slide, 2 slides now. And this is the kind of data, the kind of patients that were being seen early on, where there's a CT scan showing widespread COVID-19 and the pulmonary features associated with that, pneumonia, and then also ischemic strokes occurring in the brain. And so this was some of the earliest data. It's hard to interpret these numbers without a context, and that's often lacking in the literature. We'll get to that in a little bit in a few moments when there's a nice meta-analysis that we'll talk about and some additional data. Let's move on now to Italy. The Italians were obviously rapidly and hard hit by COVID-19. They were also more forthcoming and willing to share in real time the data, and ultimately worked hard to get a lot of that out as quickly as possible in the literature. They saw a very high rate of comorbid COVID-19 and stroke, substantially higher than in China. Here's a graph of weekly admissions of patients with neurologic disease in Lombardy. The non-COVID-19 admissions were relatively stable. The COVID-19 admissions associated with neurologic events had this clear and rapid spike, nearly doubling their normal admissions of neurologic events in a relatively small hospital system in this area. And the nearly, I'm sorry, we're missing the top bar of this graph here, but nearly a significant fraction of those patients were admitted with neurologic, with stroke. I'm sorry, so the COVID-19 patients are over here in the right column, where they had a nearly 76% rate of stroke in patients admitted with COVID-19. And they showed importantly that this was really significantly associated with both a severe increase in in-hospital mortality and then a significant impact on a grading scale we use to describe the severity of stroke, the modified Rankin scale, where a large number, it's a numerical scale up to 6 being death, 5 being bedridden. Their average score was at discharge was a bedridden patient, which is associated with a severe stroke. And the number of patients who had a good outcome, defined by the neurologist there, was substantially lower, as you can see, in patients who had COVID-19 as a comorbid diagnosis. And so this is when we really started to appreciate that it wasn't just happenstance, there was an actual association. We should go first to, let me go first to the UK and we'll bounce back, the slides are out of order. So as we go over to London, the UK, they started early on a study group called the CoroNerve Study Group that tracked across the UK neurologic events related to COVID-19. They have a case reporting map that's updated in real time. You can follow them on Twitter. We're actually going to have their lead investigator give neurology grand rounds a little bit later this fall. And what they described was, in the Lancet, was a significant increase in cerebrovascular complications in patients with COVID-19. You can see that peaks in the 6th, 7th, and 8th decades. And there was a predominance of neuropsychiatric syndromes, although that's not immediately related. But what I will note is that even in this relatively small and rapidly generated cohort, there were strokes occurring in age groups where we typically do not see them, particularly here in Los Angeles. So in the 5th decade, it's not uncommon, but they had a substantial number, stretching down as young as in their 20s and 30s. And so that really starts to tell you that there probably is a true association there's certainly an increased risk of stroke in these later decades that is part and parcel of the age group. But when you get an association in these decades, it really starts to tell you that there's something, that there may be a true biologic association. Let's go back now to New York. And obviously, again, New York City hit very hard by the pandemic early on in the spring. They did two important studies. There were three relevant ones, but two important studies that came out. First, they demonstrated an 8.4% risk of stroke among hospitalized COVID-19 patients. This is just a workflow demonstrating how they got to that number, looking at all the patients who were admitted at NYU, and then those that were designated as either COVID neuro or non-COVID neuro, and then confirmed by imaging, which is not a necessary step, but helpful to demonstrate the true presence of a stroke. There was another analysis done by the folks at NYU comparing the rate of stroke for patients hospitalized with COVID-19 compared to the prior several years of influenza. We know that viral infections raise the cytokine profile and in some indirect way increase the risk of stroke, and vaccinating against those diseases lowers that risk. And so here what you can see are, these are some of the patients. This time graph was done to illustrate the onset of stroke in orange as a function of days of COVID-19 symptom onset, hospital admission, and ICU admission. So you can see that in many cases, this was occurring 7, 14, and even 20 plus days out from the initial onset of symptoms. However, in some patients, it was occurring simultaneously at the onset. And so that was then described in a series of cases in the New England Journal, in which we had younger folks, typically less than 55, presenting with large vessel ischemic strokes, the most devastating form of stroke, very early on. And so this, again, as I said, as the data from Italy demonstrate, this suggests a true and significant association of the virus with this cerebrovascular complication. And certainly this table here demonstrates the risk I talked about, the increased risk of stroke in association with COVID-19 as opposed to influenza. So in an adjusted model for age, sex, and race, it was 7.6 odds ratio of having a stroke if you had COVID-19 as opposed to influenza. And so these things tell us then that there probably is a significant and meaningful association. Our own UCLA experience has been varied. As many know, West LA has seen certainly not the worst of the Los Angeles pandemic experience. I've just pulled several cases that I was aware of. Here, a young lady, 43 years old, family members with COVID. She did not have any respiratory symptoms at the time of presenting when she developed right-sided weakness and aphasia. She came into the hospital, found to have this atypical clot in the internal carotid artery. I say atypical for several reasons. Number one is that most commonly carotid artery occlusions occur at the bifurcation of the carotid artery, as shown here, not several centimeters distal, where we would not expect to have atherosclerotic narrowing or other changes, nor would we necessarily expect to have arterial dissection. And so this, again, is another example of a fairly atypical stroke that occurred in a younger patient early on, later developed COVID-19, tested positive for COVID-19, and developed a low-grade pneumonia. But stroke was her presenting symptom. Here, another gentleman who we've cared for recently in the ICU, 60-year-old gentleman, severe ventilator-dependent COVID-19, had an anoxic event, survived that, and actually has very little stigmata of significant anoxic brain injury, but does show multiple cerebral microhemorrhages here, in the cerebellum as well, that have also been described in association with COVID-19. So, the features that are occurring in the brain are atypical from what we typically see, and therefore does raise an important question about the mechanisms. Here's that meta-analysis that is accepted in the Journal of Neurology, but not yet published in its final format. This is a very good meta-analysis. As you can see, it looked at a number of studies that include some from China, but mostly from Europe, that were published somewhat later compared to earlier data. What they described then are fairly disturbing trends. Number one, a 1.8% risk of stroke in hospitalized patients with COVID-19. To give some perspective, that's about roughly about 3 times normal if you look at a broad inpatient population, and twice the risk of SARS-CoV-1. And again, consistent with the data from New York, roughly 8 times the risk of the 0.2% typically associated with influenza infection. They also demonstrate that if you have COVID-19 and develop a stroke, you have a severely increased mortality, nearly 45%. And that's quite staggering. And then even more concerning, as we've seen across the data, but now here confirmed in a nice meta-analysis, nearly half of the COVID-19 related strokes in the young are occurring in the absence of COVID-19 symptoms at time of presentation. And so this has prompted then, this has prompted a widespread recognition that what we should be doing is giving strong consideration of COVID-19 in patients presenting with acute stroke. And of course, that presents a significant challenge because one of the main treatments, several of the main treatments for acute stroke involve rapid and emergent evaluations in order to revascularize the brain. And we have to slow down in order to make sure that we're doing this with COVID-19 testing and appropriate precautions for our resident health staff and the physicians who are caring for these patients. And so there's been a move by the American Stroke Association and other international organizations to adopt an approach to make sure that we're testing all acute stroke patients, particularly younger large vessel patients, for COVID-19 as early as possible. Let's move on now to talk about the reciprocal interaction that I mentioned early on. I've shown you now data suggesting that there is an association of SARS-CoV-1 and COVID-2 infection with acute stroke. There may be a reciprocal interaction in which a prior history of stroke increases the risk of a severe COVID-19 infection. And while I don't have answers to tell you about why this might occur, it's certainly something that I think needs to be deeply explored. As I was speaking with Brigitte before the talk started about her work on how smoking can influence the risk of severe infection, I think there are interesting similar mechanisms that can inform us broadly about cerebrovascular disease that occur in this paradigm. So here's a nice meta-analysis showing patients mostly looking at the Chinese studies that came out early on, comparing the rates of mortality, mortality and severe COVID-19 infection in folks who have cerebrovascular disease as opposed to those who do not have cerebrovascular disease. And what we see then is in the meta-analysis approximately a twofold risk of both having a severe history of cerebrovascular disease, predicting a severe COVID-19 infection, and also predicting the mortality associated with that infection if you have this history of cerebrovascular disease. And so we think this is real, but I think totally unexplained and needs to be explored in greater detail. The World Health Organization has put together some guidelines for trying to decide if we think a stroke is in fact associated with SARS-CoV-2 infection. They have two possible categories, probable and possible. This graph that they included, this talks, and the paper itself talks broadly about the neurologic complications associated with COVID-19. And I thought that this was a very nice graph to put in the temporal expectations of where these things occur. What we see is that cerebrovascular disease can span from very early on to often quite late, and occurring often sometimes weeks after the initial event. Typically folks will test positive through nasopharyngeal RNA testing, but also have, if you don't catch that, antibody stigmata, and those are the guidelines. So probable association of a stroke associated with SARS-CoV-2 would be one in which a patient has tested for SARS-CoV-2 but has no traditional risk factors. And then a possible association is if they do in fact have other risk factors, making it difficult to determine precisely. And just they sort of left that up to clinical equipoise. I wanted to review briefly some of the radiographic presentations of SARS-CoV-2 in the brain, and there's some pathology associated with this that leads into the second phase of the talk. There have been descriptions, first of viral encephalitis. Here's a larger example where both in the anterior orbital frontal lobe, just above where the olfactory nerve sits, there have been descriptions of encephalitis, presumably due to SARS-CoV-2 in that region. And then also here an example where there's been CSF penetration and involvement in the medial temporal lobe. The other salient feature that's been described that's clearly associated with SARS-CoV-2 is this so-called necrotizing encephalopathy, in which you have acute, we think primarily ischemic injury that then is associated also with early hemorrhagic transformation. And this is termed a necrotizing encephalopathy that's thought to be due to primary SARS-CoV-2 infection in the brain. And then finally, ischemic stroke, here a CT showing two different patterns, a right MCA lesion and also a left posterior cerebral artery stroke. Here are some other examples though. As I mentioned, the pathology radiographic presentation and pathology can be quite varied. Here's an example of a patient with a large intracerebral hemorrhage occurring in the anterior frontal lobe, also with microhemorrhages in the deep part of the brain. Here's another example of a patient with a hemorrhagic stroke, some component of subarachnoid blood, and that's also visible here, microhemorrhage in the anterior frontal lobe. And the pathology shows inflamed endothelia. This is a brain biopsy taken from this patient. And we see inflammation and looks like lipid and water deposition, edema in the perivascular space here around the one of the smaller vessels in the brain. Here's another example, another biopsy from a different patient, showing again here microclots within the endothelium within the biopsy tissue taken from the diseased region. Here again, the suspicious pathology for microocclusion of the vasculature. And so, and then you're again examples of those microthrombi occurring in the small vasculature. So what are the mechanisms? This is taken from a review in which the multiple potential pathways that occur broadly in SARS-CoV-2 infections and the relationship to possible endothelial damage was proposed. We of course know that at least in the lung, the SARS-CoV-2 appears to use its spike protein to bind ACE2, and then in the lung appears to require the activation of this enzyme, serine protease TMPRSS2, in order to cleave the S protein and gain entry into the cell. This could cause direct virally mediated cytotoxicity to endothelia. That's one potential mechanism. The second that may be particularly relevant, stroke and the brain, is dysregulation of ACE2 and the renin-angiotensin system as a result of the binding. And at least, again, in cell culture models, it appears that binding of the virus to ACE2 downregulates ACE2 and probably competes for its enzymatic action, which is to convert angiotensin 2 to angiotensin 1 to 7, and to a lesser degree, the peptide angiotensin 1 to 7. And these appear to have positive effects generally in the normal circumstance on tissue remodeling, blunting inflammation, and regulating vascular permeability. These are all mechanisms that could be associated with stroke. And so we'll talk about that in greater detail. The third possibility is that there is binding and endothelial inflammation that results in a decreased fibrinolysis and a prothrombotic state that could occur systemically or locally. And of course, some strokes occur because of proximal embolism, heart clots forming in the heart or in large vessels in the chest and then migrating up into the brain. And whether that is a major contributor to the association of SARS-CoV-2 and stroke is unknown. If that were true, then anticoagulation would be the primary treatment and we should see those strokes go away. It's not particularly biologically interesting, so we haven't made it a focus of our own work. And then finally, the fourth mechanism has been this sort of modulation of cytokine release and the indirect effects that has then on endothelium and potentially chronically diseased endothelium that may increase the risk for stroke. We put together a proposed set of pathologic mechanisms involving the cerebral endothelium and their relationship to stroke that might be slightly more informative about the specific mechanisms. And this is from a review article written by one of my students who's now in med school and executed during the pandemic and under review currently, where we talk about these various mechanisms. So certainly this modulation of the renin-angiotensin system, which normally has vasodilatory and neuroprotective effects in stroke, is one potential mechanism. A second is understanding whether the virus can in fact get into the brain endothelium and what it would do once it's in there. And so one of the main questions that we'll address in some of our data is what are the enzymatic steps required for viral invasion the same in the brain endothelia as in the lung? And then we know there is evidence that once ACE2 is modulated and there is a shift in angiotensin receptor signaling, that this can be pro-inflammatory. Two of the most commonly increased cytokines are known to have direct action on brain endothelia, including the IL-6R receptor. These can then also go on to produce a cytokine storm and also activate particular T cells. And so this chemokine signaling and T cell homing can be an indirect activation and targeting of the brain endothelium that can lead to blood-brain barrier leakage. This can then allow the virus potentially to get through and into the brain, where ACE2 expression on parasites has been implicated as a potential disease mechanism, and we'll talk about that briefly. And then finally, the activation of complement signaling within the endothelium is known to be a risk factor for chronic cerebrovascular disease and then also known to worsen stroke outcomes. And so this may be a functional and important mechanism through which SARS-CoV-2 can either directly attack currently diseased, chronically diseased endothelia, or potentially be triggered, complement signaling triggered by SARS-CoV-2 direct invasion. And so this is where we started. Is there, in fact, viral susceptibility of the brain endothelium, and then if so, what mechanisms are triggered. So the rest, and so then we talked in this review about some of the overlap between these mechanisms and what's already known about the mechanisms in stroke. And so we pulled out drugs that target the mechanisms I showed in the prior figure, and then talked about whether there was already evidence of benefit, at what level that evidence was, and whether in some cases there might be evidence for harm, as in the case of the anti-IL-6 receptor blocking antibody, which is known to increase the risk of stroke. So let's move on and talk first about our primary questions. So ACE2. ACE2 thought to be the the likely receptor, and it's implicated in carotid atherosclerotic disease. It regulates neurovascular response and appears, if you knock it out, to attenuate atherosclerosis. So it has a reparative phenomenon. But while these data do show ACE2 expression in carotid artery endothelium here, whether ACE2 is expressed in the brain remains a somewhat unknown question. This is data from the Allen Brain Atlas from human brain single cell isolates. These are neuronal populations primarily. You see in the top bar, in the bottom heat map, you see different neuronal subsets. In the top bar, you see absolutely zero expression of ACE2, undetectable in this study, which is one of the definitive transcriptomic databases of the brain. There's a very nice neurovascular study, single cell data from Christopher Betzelholz, who was just here giving neurology grand rounds not too long ago, where he described ACE2, robust ACE2 expression in mouse parasites, that they were, in his single cell database, the predominant expressor of ACE2. And this allowed, is shown here in the microscopy, the ACE2 signal is almost exclusively in mouse parasites. And this spawned a parasite hypothesis. But there are significant and important functional differences both in the ACE2 sequence in mice from that in humans, and then also significant differences in murine renin-angiotensin systems compared to humans. And so whether this is directly relevant to SARS-CoV-2 or not is somewhat still unknown. So that's where our work begins, and I'll move briefly through the data. We work generally with my collaborator and close colleague, Dr. Naoki Kaneko, in radiology. Dr. Kaneko and I have been working on, for the last several years, developing patient-specific cerebrovascular models. This is a technique where we can use patient-derived imaging that we get routinely in the clinical space, like a CT angiogram, and then use that data to create a mask and then 3D print that mask out, creating then, in some cases, a replica of the entire middle cerebral artery territory vasculature at scale, and incorporating various normal and variant pathologies. Naoki's been using this to develop a program looking at cerebral amyloid biology in his 3D precision models, where he can use that, create a silicone model that we then endothelialize. This is the dome of that aneurysm, and we can look at morphologic differences in endothelial cells, and recently looking at gene expression within those endothelial cells within the model, at mechanisms that drive aneurysm growth. My colleague and I, along with Naoki, my colleague Dr. David Liebeskin and I have an NIH grant to study how to use this technology to better understand cerebral atherosclerosis. And so in this model, we use a similar technology where we can take the patient-derived imaging, create a model, in this case, of a stenotic middle cerebral artery encased in silicone, referred to it as the box model, endothelialize that in 3 dimensions, and then you put flow-based culture through the system, allowing us to study events both in real time and the impact of various flow forces that relevant to human anatomy that are occurring in endothelial cells. So as the pandemic broke, so here's an example of what that endothelialized model looks like in the stenosis. And we've looked at things like VCAM expression, which goes up in the post-stenotic segment of the vessel. And so we have a project to look at this. And as the pandemic broke, we found that this might be a useful model, ex vivo, relatively easy to reproduce, based on human anatomy, that we could use to better understand SARS-CoV-2. So again, returning then to our primary goal, we started with the really simple question of, is ACE2 expressed in the brain? And working together with Harley Kornblum's lab and a postdoc in Harley's lab, Deepthi, they're working on phenotypic transitions of endothelial cells and glioma, and as a result have access to a human brain endothelial cells isolated from temporal lobe resections occurring at the medical center. Normal tissue was used. They isolated endothelial cells based on CD31 positivity using MAX, and then performed bulk RNA-seq of those endothelial cells. Shown here in orange, we see no baseline expression of ACE2 and nearly undetectable expression of a primary protease implicated in the lung in viral entry. Rather, we see high levels of furin, and we're exploring other proteases that might be essential for viral invasion. But we start with a relatively low level of ACE2 in human brain. So this begs the question then, is cerebral endotheliopathy possible? This has been implicated in the lung here at a review of how this might happen with viral invasion. It's been shown in the literature to occur in other organs like the kidney and the lung. Here the arrows pointing to viral inclusion bodies within the vessel wall. But I think it's unclear and hasn't been shown in the pathology in human brain yet. So we used our endothelial model then, three-dimensional model, to ask some basic questions. In the model anyway, is ACE2 expression detectable? And when we culture HUVEC cells, this is a human umbilical vein endothelial cell, in monolayer we see very little ACE2 expression. Then when we put this into three-dimensional culture but without flow, we see an increase in ACE2 expression. And when we apply a flow force, we see a greater increase, and that this was both flow dependent and vessel size dependent in HUVECs. In brain cells, then in brain endothelial cells, what we show is similar to HUVECs. As we apply a flow force, we see an increase in ACE2 expression at the transcriptional level. And here just showing in monolayer culture, we do in fact see in purple ACE2 expression, but it's relatively low and restricted to an area around the nucleus with very little cell surface expression. Now I'll show you data from our model where we endothelialized. And to really get at whether the vasculature is susceptible to SARS-CoV-2, we collaborated with Dr. Sandro Sato, who is a postdoc in the Asai lab at UCLA. Sandro has been busy creating these very unique liposomes that express viral S protein on the surface, looking somewhat like this with multiple spike proteins around the surface. Looks somewhat like the virus. It's fluorescently labeled in the center with a rhodamine signal. What we did in this set of experiments was first, in the upper panels here, add the liposome, either with or without S protein, to monolayer cells, either HUVECs or HBMECs. I'm sorry, here I'm just showing you the HBMECs, and what we see is that in brain endothelial cells, in monolayer culture without a flow stimulus, we see very little S protein, in fact, undetectable S protein liposome uptake. when we then take this to our 3D model, in which we take a partially stenosed middle cerebral artery from a human patient and create an ex vivo model of that, endothelialize it with brain endothelial cells. Here in the control, we see basically no rhodamine signal despite ACE2 expression in the flow model. However, in the S protein liposome, we see that there are focal regions of uptake with rhodamine signal that are scattered throughout, typically in the stenotic or pre-stenotic segment. And so we do think that there is a dependency of flow for viral susceptibility in brain vasculature. And while we haven't definitively shown that this is dependent on ACE2, that's part of our next step. In addition, we utilized this type of a system to measure the endothelial response to SARS-CoV-2 S protein. So here, if you take, again, monolayer ACE2 expressing HbMECs or HUVECs, and you add the trimer of SARS-CoV-2 S protein that is known to bind to ACE2, and then look at focused gene expression using the nanostring platform and direct RNA hybridization, measuring 785 genes, we see that there is a very specific, relatively limited, because we're only adding the S protein, but a fairly specific increase in gene expression, that changes in gene expression that occur within HbMECs that was unique from that in HUVECs. And when you compare the differentially expressed genes in human brain endothelial cells compared to that that was differentially regulated in HUVECs, we see several interesting features. I'll show this, the volcano plot, but I'll show a table that illustrates some of the key brain-specific endothelial response genes. Number one is complement. So we do see that SARS-CoV-2 S protein binding to brain endothelial specifically increases C3 and complement targeting. We have a number of other interesting genes involving IL-6, IL-9, IL-15, and the viral response and RNA sensing mechanisms that were differentially expressed in response to SARS-CoV-2 S protein. So we have a number of next steps. This is obviously still preliminary work. We have developing a collaboration with Mount Sinai that have over 80 brains of patients with COVID to explore in greater detail the ACE2 expression and comorbid cerebrovascular pathology. Our AHA-funded project working together with the SciLab is, what I showed you is mostly our macrovascular modeling, but we have a large project together with the SciLab and colleagues working on microvascular thrombosis and whether that is precipitously increased by SARS-CoV-2 infection in brain endothelia. We'll be able to collect from our macrovascular model endothelial exosomes in collaboration with someone at my colleague at UCSF to look at complement excretion in endothelial exosomes as that's been associated with cerebrovascular disease. And then we're planning to do similar gene expression studies, this time using full RNA-seq, to better understand the true pathologic mechanisms triggered by SARS-CoV-2 infection in brain endothelia. So I think we reviewed a variety of data. The conclusions that I showed you, I think, review the literature demonstrating quite clearly that I think stroke is a feature of SARS-CoV-2 infection that's firmly established now. It plays, cerebral blood flow probably plays a critical role in determining susceptibility. And I think then important to understand how chronic risk factors like hypertension that increase cerebral flow transiently may in fact drive susceptibility to the infection. And then I tried to show you data relatively briefly that there is a unique brain endothelial response that might inform both the interaction of SARS-CoV-2 with stroke, but also may provide some clues to understanding chronic cerebrovascular disease. I would just want to thank the members of my lab and our various collaborators, including Dr. Tsai, Liebesky and Kornblum, and Dr. Rexak, as well as collaborators outside. Particularly thank the Stem Cell Center for their funding, as well as the American Heart Association. And, we've been working here for, just after the flu pandemic. We're persisting now during this one. But particularly just to call out members of the lab who worked under the duress of the pandemic, including those featured here. Yutaro Komuro worked on the gene expression. Dr. Kaneko spearheaded most of the work. Dr. Lee Guo, technician in the lab who's worked on the modeling extensively, as well as Jenny On and Visesha, a student who worked on review articles. And then Dr. Sada generated the liposomes that we have used and continue to use extensively. Thank you very much for allowing me to run slightly over. And if there's time, I'll take questions. If not, please email me. I'm happy to discuss those.
Thanks so much, Jason, for that really thorough review. And it's really exciting to see the modeling that you're doing. And hopefully will give us new insights into this disease. And I was kind of horrified by the numbers that you presented in terms of the percentages that have these neurologic risks, which of course is a really important problem. So are there any questions? I know we're running right up on 1 o'clock, but are there any specific questions? I had a couple, and maybe we'll just have maybe take time for one. So it looks like different endothelial cells might be important in terms of the risk of this. So I wondered if you thought that there might be specific differences across different endothelial types that may be responsible for this response that you're seeing to the S protein, and whether you have any thoughts about how that could be different or why that exists.
Well, we know that, there's a wide variety of endothelial heterogeneity across the body, and that even within the brain, those cells that make up the larger vessels do have a functionally different behavior than say the microvasculature, which is able to regulate its permeability to a greater degree. And so I think this is an important question. It's hard to model because these primary human cultures of different cell types from brain vasculature don't really exist well. And so I think it'll be a little bit unknown. I think one thing that we're very interested in doing is getting into the pathology, because it allows us to look at those large vessels from patients that have been infected. And at that scale, you can really look at, are there differences in large vessels versus small vessels? We also working with one of my colleagues in neurology, Jessica Rexak, who has a large single cell database from patients with neurodegenerative disease. And that may also inform whether the mechanisms of SARS-CoV-2 infection are relevant.
Great, and it looks like we have one question, but it looks like I'm not able to see it right now, so I'm sorry.
Oh, yeah, so Hui Yi has asked, saying that she's volunteering that she's established immunohistochemistry for TMPRSS2 and ACE2 and furin, and that they have normal mouse brain tissue already stained for those targets. And she'd be happy to share that. So that would be great.
Fantastic. And that really is the goal of these seminars, is to set up collaborations. And so thank you. Thank you for that. And yeah, so if there are any further questions, please feel free to email Jason, like he said. And yeah, thank you so much again for that really great seminar. And then just a reminder to everybody that next week will be on Friday at noon, as we'll be picking up on the COVID seminar series on Friday at noon. So thank you all for joining us, and we look forward to seeing you next week. Okay, thanks. Bye.
Thank you.